I'm sorry about that. Thank you, everyone, for joining us tonight for the presentation of over-the-counter hearing aids, Rationale for Support. First, I want to thank our captioner this evening, Cindy Thompson of Alternative Communication Services. Thank you very much, Cindy. Tonight we have with us Stephanie Czuhajewski, who has more than 2 decades of nonprofit leadership experience and is currently the Executive Director of the Academy of Doctors of Audiology, also known as the ABA. We also have Dr. Alicia Spoor, who is the owner of Designer Audiology here in Maryland, and she is the President-elect of the Academy of Doctors of Audiology and is also the Legislative Chair of the Maryland Academy of Audiology. Welcome to both of you. I'm very excited about this webinar tonight. It is a hot issue right now, and we're very glad that hearing loss is finally getting some media attention and that we're finally in a position to do something to help people with mild to moderate hearing loss get some help. So I'll let you go ahead and get started.
Thank you, Nancy, and thank you, attendees, for joining us for this very important conversation. ADA has actually been thinking about the topic of alternative hearing aid delivery models for the past 40 years. And part of the reason for that is because at the time that audiology started dispensing hearing aids, audiologists were themselves an alternative model of hearing aid delivery. So it's a very interesting dynamic. ADA has been thinking about this more in earnest, certainly over the past 3 years, since we had the opportunity to sponsor what was then the IOM, or the Institute of Medicine, workshop on hearing loss and healthy aging, which took place in January of 2014. So there we heard so many compelling presentations about the gap between the number of people who could be helped with a hearing aid and the number of people who actually get treatment. So of course, as many of you well know on the line tonight, the statistics are really staggering, and today, liberally, hearing aid adoption rates stand at around 25%. So hearing aids themselves have improved dramatically over the past several decades, yet adoption hasn't. So why is that? In my portion of our time together today, we'll discuss a little bit about the background and then some of the information that has formed ADA's thinking about the issue of direct-to-consumer or over-the-counter hearing aids, the problems and the solutions around affordable, accessible hearing care for adults, and then in our view, the role of those devices in the hearing healthcare system. So just a little bit of background on the history of ADA. As I mentioned, there was a point where audiologists did not dispense hearing aids, and really ADA was founded because there was a group of audiologists who were at the time viewed as quite radical, who decided that they wanted to dispense hearing aids for profit. So after a U.S. Supreme Court ruling in 1978 forbidding professional societies from having codes of ethics that would restrain trade, ASHA actually rescinded ethical guidelines that were in place at the time that wouldn't allow private audiology practices to dispense hearing aids for profit. So this really allowed the private practice of audiology to flourish, and practices grew in the 1980s. So too did the profession in terms of its qualifications and educational requirements. In the late 80s, it was determined that there really was a need for a clinical doctorate degree to take audiology to the next level and really give audiologists the type of training and clinical expertise that they needed to take care of the patients in the future. So with that was born the AUD, or the Doctor of Audiology degree. And ADA has always really been on the bleeding edge in that we were one of the strongest proponents of moving from a master's degree to a doctorate degree at a time when there was a lot of pushback around that. So in the 70s we did something provocative, in the 80s we did something provocative, and then in the 1990s the first AUD degree was conferred, and by the mid-2000s it was the entry degree for audiologists entering private practice. I don't know where, there we go. So we continue on this forward-thinking path. In addition to talking about the Over-the-Counter Hearing Aid Act tonight, we will touch a little bit on another piece of legislation working its way through Congress called the Audiology Patient Choice Act. So going back now from the workshop in 2014 that was held at the IOM, we know that in 2015, the President's Council of Advisors on Science and Technology, or PCAST, held some sessions and formulated a report that was sent to the President of the United States and also published and disseminated publicly. And in that report were a number of recommendations that ADA carefully evaluated. Someone told me once that it takes 20 years to become an overnight success. As Nancy sort of referenced, that has certainly been the case with the well-deserved attention that's been given to the importance of hearing loss recently. So for the past 20 years, there have been a lot of things going on, and then really it's sort of come to a head over the last 3 years, starting with the IOM, and then looking at the PCAST and some of their recommendations that came out. So in looking at the 4 recommendations that they had, they included people from medicine, technology, science. One of the folks who was heavily involved was Dr. Christine Castle, who was with the National Quality Forum, Thomas Camber from the Older Adults Technology Services, Charlotte Ye with AARP, and they even requested input from other professionals and experts like Dr. Lin at Johns Hopkins. So in looking at the recommendations themselves, one of them was that the FDA should designate a distinct category of basic hearing aids, non-surgical air conduction hearing aids intended to address bilateral, gradual onset, mild to moderate, age-related hearing loss, and adopt distinct rules for those devices. The second recommendation from PCAST was for FDA to withdraw its draft guidance on the November 2013 personal sound amplification products, or PSAPs. The third recommendation was for the Federal Trade Commission to look at the delivery of hearing health care and make some determinations that were parallel with its eyeglass rule and require audiologists and dispensers who perform diagnostic hearing tests, hearing aid fittings, to provide the customer with a copy of their audiogram and everything else that goes with it, including their audio profile, at no additional cost in a form that could be used by other dispensers or hearing aid vendors. And then similarly, in efforts like the contact lens rule, to ask the FTC again to define a process for patients to authorize hearing aid vendors in state and out of state to obtain a copy of their hearing test, the results, everything that was around the results, including that audio profile, so that the testers would furnish those, again, at no additional cost. So as we looked at those, we provided qualified support. ADA provided qualified support for all 4 recommendations, and we did so for a number of reasons. We feel that it is very important that we move the needle in terms of adoption rates. We feel that it's very important for competition to be increased in the hearing healthcare space. And we feel that this can be done in a responsible manner through the FDA and through the legislative process. So as we provided that qualified support, we did make every effort to ensure that the audiologic care that is so important and successful for patient outcomes continues to be recognized and continues to be implemented. We requested that there be strong recommendations, for example, for patients to seek and obtain an audiologic evaluation. But we recognize that that pathway into the hearing healthcare system is not going to be the chosen pathway for every consumer. So we do not believe that it should be required. We also felt that the PCAST recommendations, they interchanged the terms class and category when discussing over-the-counter products. We recommended that they only use the term category at that time. We also wanted to make sure that the PCAPs would be appropriately labeled if they would be used as non-registered devices and encourage the development of PCAP standards. We also believe that all companies and all manufacturers should be allowed to make truthful claims about their products, and we felt like the recommendations would allow that. At the time, we also put in an opposition to online diagnostic testing, although we're very supportive of online screening. It was felt at that time, and still continues to be the case, that a true diagnostic evaluation can't be successfully achieved without having a good patient history, without having otoscopy, without having a lot of the things that an online true test is not yet available or able to do. But we recognize that as these things, as technology advances in that area, and once that is able to be achieved, we wouldn't oppose it in the future. So as we looked at the PCAST recommendations and our subsequent position on those, moving into 2016, the NASM committee is continuing to meet. At the same time, and subsequent to that, the Food and Drug Administration decides to hold a workshop on streamlining some of the regulations that the FDA has imposed, and they put a call out for comments and for participants in that workshop. So Dr. Alicia Spoor represented ADA there and discussed what we view as some of the biggest barriers to care at that time. So during that presentation, we pointed out that cost is an irrefutable barrier. It's not the only barrier, but it certainly is a barrier, and it's one that's been addressed by many governmental bodies over the past few years, including Congress and many administrative agencies. Many people view hearing aid purchase as the third biggest purchase that they might have in their lifetime beyond a house and an automobile. So it really is something that's substantial. And I have to note here too that many audiologists also find cost as a barrier to providing the care that they want to deliver to their patients. So independent practices struggle in negotiating prices from legacy hearing aid manufacturers, and many are moving towards unbundled delivery models that allow more transparency in that regard. Direct-to-consumer and OTC devices will undoubtedly lower the average selling price of hearing aids, and they'll also expand competition and encourage a further movement by the audiology community towards that unbundled pricing model. So additional major barriers to care that we identified during that meeting include unclear pathways to care for the consumer. It's not always easy to identify the right provider, be it an audiologist, a hearing aid dispenser, otolaryngologist, and making sure that you're getting all of the services that you're entitled to. We know that HLAA has a fantastic resource that consumers can download from the HLAA website that sort of provides a checklist of what you should expect when you go to an audiologist. But we know that not every consumer is able to access that or find their way successfully into the hearing healthcare system. And also, awareness is an incredible barrier at all levels. So awareness by the consumer about the availability of products and services available to them in the hearing healthcare space, but also really the awareness among other healthcare providers, including general practitioners, about the importance of hearing health for their patients, including a lot of the associated maladies, comorbidities, and the importance really of getting treatment as soon as possible if hearing loss is suspected. So as we continued the presentation to the FDA and in our subsequent comments, what we were really seeking were two main requests from FDA. The first of which was to eliminate the need for medical clearance for the purchase of a hearing aid. So as early as 1993, the FDA had already identified the requirement for a medical evaluation for adults seeking to purchase hearing aids as something that was not working in the way that it was intended. There was widespread use of the waiver, and there was just a lot of anecdotal evidence that people were not actually following the regulation in the way that the FDA had intended when it was written in 1977. We also know that roughly 90% of hearing loss is not medically treatable. So it makes the most sense for a consumer to come into the hearing healthcare system with an audiologic evaluation and then to be referred for a medical evaluation if it's identified by the audiologist that would be needed based on the red flag conditions that they can identify. So we requested that, and then secondly, we requested that the FDA restructure regulations at that time to allow for Class 1 medical device hearing aids to be sold direct to consumers. We know that hearing aids have been sold over the internet and through mail order for the past 50 years. So this is nothing new. What we were seeking was for there to be more standardized regulations in that regard and more widespread access for the consumer to the OTC devices. And in our view, again, this would allow for factual information to be presented. It would allow for the consumer to have more opportunity to make an informed decision about their hearing health care and more opportunities to determine where the device is purchased from should they need a hearing aid. We, again, wanted to have a requirement from FDA that the devices would have a strong recommendation to obtain an audiologic evaluation, although, again, not a mandatory requirement for that evaluation. So, working in parallel was the National Academy of Sciences, Engineering, and Medicine, who had, after the workshop in 2014, formed a committee to really take a more in-depth look at accessible and affordable hearing health care for adults. Now, the committee included physicians, audiologists, consumer advocates, and other experts who met for about a year. They had a series of workshops. They had a number of presentations from a variety of different stakeholders, and then they had what I can only imagine was a considerable amount of internal debate before reaching consensus recommendations in June of 2016. So they had 12 recommendations that came out of that, and I think it really is important that we think about those holistically. So they wanted to improve population-based information on hearing loss and hearing health care, develop and promote measures to assess and improve quality of hearing health care services, remove the Food and Drug Administration's regulation for medical evaluation or a waiver. I think we can all start to see the pattern here in that thinking for recommendation number 3. Empower consumers and patients in their use of hearing health care, improve access to hearing health care for underserved and vulnerable populations, promote hearing health care in wellness and medical visits, implement a new Food and Drug Administration device category for over-the-counter wearable hearing devices, improve the compatibility and interoperability of hearing technologies with communication systems and the transparency of hearing aid programming, improve the affordability of hearing health care, evaluate and implement innovative models of hearing health care to improve access, quality, and affordability, improve publicly available information on hearing health, and promote individual, employer, private sector, and community-based actions to support and manage hearing health and effective communication. ADA, as I understand it, is the only provider organization that came out and 100% support and unqualified support of all 12 of those recommendations. And we looked at it in a very holistic manner and not just looking at number 3 and number 9 and number 8 and saying, well, we like those but not the others. We feel like the committee really did its due diligence in terms of the type of research and input that it was receiving. We felt that it was a very independent body and that it came out with the recommendations in earnest after really listening to all of those stakeholders. We did note with interest that the recommendations were consistent with some of the PCAST recommendations and also with many of the presentations and thinking that was given at the FDA workshop, particularly from consumers and then also through the ADA presentation as well. So subsequently, the National Academies had an additional meeting in December, which followed on the heels of the initial OTC hearing aid bill introduction, which happened very late last fall. And at that meeting, the FDA proactively stated that it does not intend to enforce that requirement that individuals 18 years and older get the medical evaluation or sign the waiver prior to purchasing hearing aids. So ADA was very pleased about FDA's decision to cease enforcement of that, and it's our understanding that they're taking steps to roll back the regulation itself. But we do note that there are many states who also independently still require that medical evaluation or the waiver, and unless or until the OTC Hearing Aid Act is passed, you would have a very inconsistent model in terms of whether or not that would be required from state to state to state. So ADA believes that the national legislation, the federal legislation, is needed in order to ensure that that medical evaluation requirement is removed across the nation so that everything would be consistent. So with that, I hope I've provided a little bit of a background that sort of has been forming ADA's thinking on this issue over the past several years, and at least demonstrated that we've had a consistent position across all of these different independent bodies and in some of our comments. So with that, at this time, I'd like to turn it over to Dr. Spoor, who will actually get into the legislation and the legislative initiatives themselves.
Thank you. And thanks for attending and for HLAA for putting this together. So I want to start out with what I would call the most senior legislation that you're going to see presented tonight, and that's the Hearing Aid Assistance Tax Credit Act. And full disclosure, I'm 36 years old. I remember being in graduate school when I was going to school in the district, and I think the tax credit had been introduced at that point in time. So this is not a new concept to a lot of people, but it is something that has been reintroduced, and you can see the Senate Bill 48. It was introduced very early in this congressional session in 2017-2018. And basically what this legislation says, for anybody that's not aware of it, that it would allow anyone who's purchasing a hearing aid to take a tax credit up to $500 once every 5 years. And the only stipulation so far is that the hearing aid needs to fall under the FDA's Food, Drug, and Cosmetic Act. So there are a lot of unanswered questions about that, which I'll come back to in a minute. And that also, if you take that statement one step further, shows that if you were to buy 2 hearing aids, then you would have a $1,000 tax credit. In the prior legislation, there has been a $200,000 income eligibility cap for the household. So that rules out some of the people that might have a large income being able to take advantage of this tax credit. But some of the questions that have come up with this hearing aid tax credit bill since the introduction of the over-the-counter hearing aid piece is what happens if you don't go to a provider to obtain the hearing aid, what happens if it's a PSAP, which is equivalent to a hearing aid right now, and they're not being regulated, does that still fall under that category? And there's a lot more questions that have been coming up. But that being said, as Stephanie Czuhajewski just noted, We know that cost is a barrier for many people. It's not the only barrier, but it is a barrier, and you're going to see some of the evidence come out, and there's lots of literature and studies that can show that too, which I can reference at the end. But when cost is an issue, this is one way to get around it. And if costs were truly not an issue, then this piece of legislation wouldn't have the support that it's having in Congress over and over again. So ADA has supported this, as well as many other both hearing aid manufacturer groups and provider groups, and it's something that has been introduced for a long time but hasn't really gotten the momentum to move forward. So this is really the brunt of why I think most of you are sitting on this webinar tonight, which is the Over-the-Counter Hearing Aid Act of 2017. And I do want to point out that this is technically the second time that it has been introduced into Congress. It was introduced at the very, very end of the 2015-2016 congressional hearing, but as you'll see, it was reintroduced in both the Senate and in the House on March 21st of 2017. So we're really going on about 2 months that this over-the-counter hearing aid bill has been in Congress this time, and it was introduced in December before. So you're really looking at a lot of information that's been out there for about the last 6 months. And I do want to know, especially coming from the audiology standpoint, and I think some consumers, which I cannot speak on behalf of, I can tell you my patient views, but HLAA could probably give a better view on what the consumers are saying, but there is a lot of misinformation that is out there about this Over-the-Counter Hearing Aid Act. And so I would strongly encourage you, you can look these two bills up on congress.gov. And they are very short bills. They are only 6 pages. They are essentially double-spaced. They have very small margins when you actually read them. And I would highly encourage you to read it to see what is actually written in this legislation. But basically, the legislation is going to define what an over-the-counter hearing aid can be. And as many of you have heard, we've talked about mild and mild to moderate. It provides regulations for the control of OTC hearing aid sales. And so they're talking about safety and efficacy and outcome limits and more that might be placed on this type of device to be sold. And it overrides the state licensure law, which Ms. Czuhajewski just referred to, about the FDA guidance the state licensure laws related to the medical evaluation and the medical waiver for the condition of sale. And it also makes the FDA guidance from November of 2013 finalized to distinguish between hearing aids and PCAST. So again, there's a lot of misinformation out there, and especially with ADA as somebody who supports it, I want to note that there's a couple things that we see in this piece of legislation. It does call out that there needs to be regulation. So right now there are a lot of options available on the market, direct to consumer. You can order via mail, you can do catalog, you can do internet-based sales, and there are no regulations whatsoever. So we don't see this as something that's going to open the floodgates. It's really something that's going to put regulations, and so we've often termed it as a re-regulation of hearing aids that are available direct to consumers. So now with this, you're going to see devices that have appropriate outcome limits, that have appropriate labeling, that have appropriate standards, that have instruction manuals, which are already supposed to be there under the condition of sale for a hearing aid, but aren't always being there. And with this re-regulation, there's actually a method that you can go back and actually start to enforce some of these issues for companies that are not looking at it. This would also allow the manufacturers of these devices to make truthful statements. So again, Ms. Czuhajewski already referred to, there's a lot of things you can get out there right now, but you can kind of say whatever you want about these devices. Some of them function the exact same way as a hearing aid. They're just termed something different if they're sold over the counter or if they're sold through a provider's office. And so you're going to see things that are actually making truthful claims about what products can and cannot do. And again, as I mentioned, the legislation as it's currently written is written for mild to moderate hearing loss. And I know there's a lot of variations as to who agrees with mild, who agrees to mild to moderate, but in the case of ADA, we have agreed with mild to moderate. And so pointing out kind of where we are in this situation, you've got the House bill, this HR 1652, and it's already been heard in the Energy and Commerce Committee. That testimony happened on May 2nd. That testimony is available to everybody. It's very interesting to listen to with Dr. Shuren from the FDA, as well as Dr. Powers and Dr. Lin, who both were there speaking on behalf of physicians and hearing industry association, respectively. And it may be combined into a larger group of this MDUFA bill. On the Senate side, the legislation was marked up on May 10th, and so you're going to see that start to move forward a little bit more in the next 24 hours as well. So as I mentioned, ADA does support this legislation. It's consistent with everything that Ms. Czuhajewski has already said. It's consistent with the PCAST recommendations, it's consistent with our FDA presentation, and it's consistent with the Institute of Medicine or the NASM recommendations. And so we have been supportive of that all along without a lot of qualifications, and of course ADA is supportive of the actual legislation as well. We also want to point out that you will see a lot of information that's available in peer-reviewed studies and research methodologies that talk about the risk of non-treatment when it comes to hearing loss could be greater than the risk of self-treatment. And I think that's really interesting from the audiological side in terms of the fact that a lot of audiologists or hearing aid dispensers or physicians who might be selling hearing aids have promoted, you know, there's a risk of falls, there's a risk of quality of life decrease, there could be a risk of graduated dementia and Alzheimer's and things like that when it comes to why you should actually obtain hearing aids and go through this process. But now that the option of obtaining hearing aids is out there, some of that information has been kind of pushed under the rug in terms of why you should actually get something that might be a little bit beneficial as opposed to not doing anything in the long run. And as I mentioned before, the legislation does require the safety, the efficacy, and the labeling and the reporting system to be addressed. None of that is written in this legislation. That's all something that there are timelines put in place as to how long the FDA would have to create those different types of regulations, but they're not something that I can speak to because they're not actually being developed. Within the legislation, they're probably being looked at the FDA, since the FDA has already mentioned that they would be looking into this at the NASM meeting in December. So the other thing that we want to point out while you're on the phone call today is the Audiology Patient Choice Act of 2017. And this is a House bill that was introduced on May 2nd of this year, so in this congressional session, has been introduced in the last two congressional sessions as well. Try saying that 3 times fast. But this essentially does 3 things. It's going to update the Title 18 of the Social Security Act, which is essentially Medicare, and it's going to allow any Medicare Part B beneficiaries to have direct access to an audiologist. So as most of you may know, in order to see an audiologist at this point in time, there's the requirement of a physician order as well as a medical necessity in order for Medicare to actually reimburse for services. So that would take off this extra burden of having patients obtain that physician order before they actually come to the audiologist and go through the testing for medical necessity. It would also reimburse the provider for any Medicare covered services that are allowed under the state scope of practice. So it's not any additional scope of practice, it's not any additional services within the Medicare system, but currently if there's a vestibular issue and you have poor balance, you might see the audiologist for balance testing, but then you would have to go to a physical therapist to be covered under Medicare for reimbursement for that type of treatment, even though the audiologist is allowed to administer that treatment under their state scope of practice, they're just not able to be reimbursed. So this is allowing for patients to have a one-stop shop or a consistent place of service for both treatment and diagnostic coverage. And then the third thing that it would do is it would categorize audiologists as limited licensed physicians, and this would just put us in the same taxonomy or category as other non-physician providers. So before we all jump off the deep end, limited licensed physicians is not a term that ADA or anybody else has come up with. That is what Medicare happens to call these non-MD providers. So we're talking about optometrists, chiropractors, podiatrists, dentists, pharmacology is trying to work towards this as well. So as I often tell people, Medicare can call me anything they want as long as they put me in the category with all those other non-medical doctor providers that are providing the same type of care that I am. And that would be the physician or the optometrists, the chiropractors, the podiatrists, and the dentists. And being very upfront, I love this piece of legislation because ADA has written it. This is drafted by us. It is moving forward because of the ADA. And so obviously we do support it. It would still allow patients to see a provider and purchase over-the-counter hearing aids if that were something that they would want to do. It would allow patients to go direct to the over-the-counter model in terms of purchasing hearing aids and then come to an audiologist if they wanted to do so. It would just give them the accessibility of seeing a provider without extra barriers. It is worth noting this does not say that Medicare should be covering the cost of hearing aids. That's a whole nother fish to tackle. This is really kind of looking at giving patients access to professional care and to have Medicare cover some of the costs that they've already covered in other services, but it does not specifically say anything related to hearing aids. Right now, hearing aids are excluded from the Medicare Part B system. And we can talk more into that, but that's a whole nother webinar as well. And again, it doesn't add any new services to Medicare, just provides you as a patient the ability to see whomever you choose for the services that you would like. So with that, we wanted to make sure we provided an overview, but we wanted to allow ample amounts of time for questions. And I'm sure, Nancy, you've got quite a few coming in. So I'm going to turn it back to you and we can move forward from there. So thank you very much.
Okay, perfect. Thank you very much. The first question comes from Dwayne Smeltzer. He says, please share your evidence for cost being a real barrier when adoption rate is the same in countries where hearing aids are free.
This is Stephanie. I'm happy to take that initially. We would be glad to send you some of the studies that we have that actually demonstrate that that cost is a significant barrier in the United States, where we have very low actually adoption rates versus what they are in other countries. Certainly there's no country where adoption rates are approaching 100% or anywhere close, but there are countries in Europe where adoption rates exceed 40%. In cases where cost isn't a barrier. And even though over there they do have issues with access and very long wait times from time to time with their national healthcare systems and so forth, they still are seeing adoption rates that are much higher than in the United States.
I can attest to the fact that...
Sorry, Nancy, I'm going to piggyback off of that too. This is the actual NASM report. It is a book. You can see that, but Chapter 4 is dedicated to hearing technologies, and you can see a lot of their studies and research that they've obtained. It starts on page 196. I have read it a couple times, but you can find some of the information and answers that you're asking for there as well.
Okay, I was going to say I can attest to that because the financial assistance page of our website is the one where people spend the most time and most frequently viewed. And our phones and email are quite busy with people inquiring about how to afford hearing aids. We get between 3 and 8 every single day of the week, and some days as high as 10 inquiries on that subject. So it is a problem. Okay, the next question comes from Brad. If OTC hearing aids become available, what capabilities might be provided by hearing aid manufacturers to allow hearing aid users to program their hearing aids using hearing profile data provided by an audiologist? Will that even be possible?
I'm happy to start with that one, especially being on the clinician side, and then Stephanie, you can jump in if you'd like to. But I can tell you that at this point in time, it's anybody's guess what might be out there. There's a lot of speculation as to what these devices might be. There's no rules or regulations or enforcement that's happening right now on devices that are direct to consumers currently. And so I think in terms of imagination, the sky's the limit. But a lot of that is going to be yet to be seen. Part of what I see as a provider is that if you come in it as a provider, and this is my personal opinion, if you come into me as a provider, I'm already providing you with your audiogram, and if you have a device that you think you can program, then all the more power to you if that's that capability. There are already devices now that let you fine-tune and have equalizers that are hearing aids from the hearing aid manufacturers that are currently being provided through an audiology or hearing aid dispenser or physician model. And so I think you're going to see lots of things, and that's kind of like asking what new technology is there going to be in the next 10 years. Some of the things that I think are being developed we don't even know about yet because it hasn't come to market and it's not regulated or it's not researched or it hasn't been rolled out. And so that's a roundabout answer to say I hope you have lots of ideas and lots of options.
Mm-hmm. Stephanie, did you want to add anything to that?
I think Alicia covered it beautifully. I think the only thing that I would add is that really the sky's the limit in terms of future technology. We've been seeing things change so rapidly, and as we think about direct-to-consumer opportunities in the future, I think we need to move away from the sky is falling mentality to that sky's the limit mentality, because I think there are many opportunities to use telehealth and teleaudiology to couple with what these technological advances will be in terms of phone applications and things that we're going to be able to download. I think in the future we're going to see a ubiquitous device really, and I think a lot of your hearing aids are actually going to be, software only. If you have a good device, you're going to maybe even be able to switch up the kind of hearing aid you have by virtue of just changing your software program.
Exciting. Exciting times for sure. Biggie said, what does it mean allow manufacturers to make truthful statements? I think she might be pitching that one to you, Alicia.
Yeah, I'm happy to start with that one. I think what you're referencing, and this is something that I'm sure Stephanie will chime in again as well at the end. Right now, what that means is that you cannot sell a hearing aid that's intended for the treatment of let me back up. You cannot sell a device that's intended to treat hearing loss over the counter. And so what's happening is you're seeing a lot of devices that are for an enhancement of hearing, or for those kind of hunter type situations where you might want an increased sensitivity of hearing, or you might want better than normal hearing. And so these are all advertising tricks that some of these devices are using, and I'm not saying it's right or wrong, but these are labeling things that PSAPs, currently personal sound amplification products, cannot say that they are intended to treat hearing loss, even though they may be used for that type of situation, or they could be technologically the same to a hearing aid that I as an audiologist would sell in my practice, but because it's not intended to treat hearing loss, you might be able to purchase it through a mail order catalog. But if it is intended to treat hearing loss and they make those advertisements, then you're required at this point in time to come through that provider, and provider being the hearing aid dispenser, the audiologist, or that physician.
And this is Stephanie, I'll just add that. So what the FDA looks at currently, and what they have counseled people through their draft guidance, their draft PSAP guidance, which hasn't been finalized, is that it's really about intended use. So the technological components of the devices could be identical, but because one device is intended for use in the treatment of hearing loss, it either has to be deemed a hearing aid and marketed and regulated appropriately and registered with the FDA appropriately, or it's not supposed to be marketed for the purpose of treating hearing loss, even though by virtue of its technological features, it may very well be able to do that. So in a lot of ways, the PSAP manufacturers, or folks who are not currently making devices that are FDA registered as hearing aids, are doing things to sort of skirt that requirement and really kind of getting right onto the edge of what's legal or not legal in terms of what they're saying about these devices. From ADA's perspective, we would like the guidance to be perfectly clear so that the playing field is leveled for all manufacturers, those of hearing aids and those of other devices, so everybody kind of has the same expectation and is held to the same standard. And that way, in that regard, we feel that people can market their devices transparently and truthfully. And we believe that companies should be able to make truthful claims about their products, as is consistent with the First Amendment.
Okay. The next question comes from Jeff. Who will write the training material for OTC sellers, or the qualifications for OTC sellers?
So this is Stephanie. I think I can start, and I can be corrected later. I'll tell you that I'm not 100% sure at the end who exactly will be sitting in a room writing it. I'll be right up front with that. But what the legislation calls for, the OTC Hearing Aid Act, is it calls for the FDA to come up with the modification to the current regulations on the sale of a hearing aid. So the FDA would be directed through the legislative process to make the regulations necessary or to modify the existing regulations in order to account and allow for those OTC devices to be sold safely and efficaciously. Now, we know that when Dr. Jeffrey Shuren testified at the House Energy and Commerce Health Subcommittee hearing a couple of weeks ago, he made affirmative statements and confirmed that the FDA would be able to do that and to do so in a way that would be safe and effective to the consumer should the legislation be passed. Okay. The next question also from Jeff, does HLAA support the APCA? And yes, we do, but I think we might be behind on posting some information about that. I know Barbara is on the webinar. Barbara, if you have a microphone, I can have you answer that. If you want to provide more information, I know I'm kind of putting you on the spot there. And I'm not sure she's on a microphone with a mic, but you will be seeing more information about that, about our support of that. Kathy writes, age-related hearing loss was the basis for PCAST and NASM recommendations. If someone has a medical history of chronic disease, trauma, or ototoxic medications, will OTC not apply and cannot be sold? And audiological management will be recommended first?
Yeah, this is Alicia. I'm happy to answer that question. The answer at this point in time, from how I understand it, and this is from me reading the legislation, is that no. If you have a comorbidity or a pre-existing condition that could be linked to hearing loss, there's nothing that would prevent you from buying some type of OTC device. That being said, I would highly recommend that you look at the Energy and Commerce hearing that happened on May 2nd, which that video is publicly available, because they did talk a lot about whether or not there would be medical conditions that would preempt like a mild hearing loss versus a moderate hearing loss in terms of the treatment that would be provided. And because I am not a medical physician, I'm not going to answer that, but Dr. Lin did go that route when he was asked that question, and so that's something that I would look into as well. That being said, part of the good stuff that's coming out of this over-the-counter hearing aid legislation, and as we've tried to move forward, especially with the diabetes side, is that we need more awareness when it comes to hearing and hearing loss and hearing prevention. And we need more awareness, and we need more data, and we need more evidence-based practices and best care and standards and everything that goes into these packages. And I think that's one of the things that this is starting to show, is where some of these areas have fallen short and where some of these areas need more things and where some of this could be beneficial. And that's not only good on the consumer side for people that are listening, and also for providers that are doing hearing and balance healthcare, but it's also good for those primary care physicians and those internal medicine and family practice that are, and gerontologists that are kind of the gatekeepers at the moment of these people, to help funnel them to where they need to be when they do have those comorbidities or co-diseases present.
And this is Stephanie. The only thing that I would add to that, I think Alicia Dr. Spoor did a great job of covering that question, is that the purchase of an OTC device and the purchase of audiologic care or treatment by an audiologist is not mutually exclusive. And this is something that we want to make sure that we continue to really put out there into the universe, is that it is not going to be an either-or decision for many people. We anticipate that the incorporation of OTC devices will actually bring more people into the system, as Dr. Spoor mentioned. And with that, they'll be able to take these devices and go to an audiologist. Or even better, start with the audiologist, get a fantastic audiologic evaluation, get your needs assessment, and get everything that's comprehensive on the front end. And then if an OTC device is something that your audiologist recommends that could work for you, then great, then go buy it and go back and get subsequent treatment if that's what you want to do. Or even better, we anticipate that many audiologists will actually sell these OTC devices right in their practices, and you'll be right there and able to purchase them on the spot and then go back and get the care or treatment from an audiologist if that's what you choose to do.
Okay. Do you know when it's likely that we will see these bills passed? Like, what's the timeline in the bills getting passed and actually seeing OTC devices on the market, do you think?
Sure. So as we understand it, the way that the OTC bill is currently attached to an FDA reauthorization bill in both the House and the Senate. The FDA reauthorization bill, by virtue of its deadline for renewal, needs to be done by sometime in September, as we understand it. So we expect that if the OTC component in the OTC legislation stays attached to the bigger bill, that it will pass along that timeline if it's successful. That said, there's no guarantee that it would pass at that point. If it does, I believe that the requirements to the FDA are a 3-year timeline from the time the bill passes until when a lot of these things would be implemented. That said, the FDA on its own has the authority to do many of these things from a regulatory standpoint without the mandate from the legislative body. So as we understand it from their announcement in December, FDA is already looking at the best approaches for implementation for OTC hearing aids. As we mentioned, they've already voluntarily removed the requirement or the enforcement of the requirement for the medical evaluation, and they're looking at rescinding that regulation. So we are really unsure about the legislative, success for the bill. But we're very hopeful that it could be passed before September, and that with that, the FDA is already working and could even be done in advance of that 3-year mandate.
Great. Barbara Kelly is online and can provide more information about HLA's support of the Audiology Patient Choice Act of 2017. Go ahead, Barbara.
Hi. Yes, we are definitely supporting that, and we will have more information on that on our website soon.
Okay. Do you have a timeline, Barbara, of when that'll be posted?
No, I don't. We've written our letter of support, and we're just about to submit it to the Academy of Doctors of Audiology. We were working on tweaking that.
Okay, good. All right. You can see there's a lot of legislative activity going on at HLAA among our small staff, but we're doing the best we can. Okay, I believe there was one more question here. Let me just scroll down. Will this presentation be available later? Yes, absolutely. It has been recorded and we'll post it. Usually it takes us about a week or so to get it posted on our website along with the slides. So definitely you'll be able to view it again and share it with your colleagues. Walmart pharmacy departments in Texas are selling hearing aids now for about 5 years. Do you think that's going to be the trend? I know that CVS also has hearing centers in their stores. What do you think about that?
Yeah, I'm happy to start that answer. Yes, Walmart and Sam's Club has been selling hearing aids. Costco has been selling hearing aids. As Nancy just mentioned, CVS, especially around my office, have been selling hearing aids. But I think there's a big difference to point out. And right now, all of that is still provider-sold devices. And what we're looking at is something that will not necessarily require, it should strongly recommend, but nothing that necessarily requires that provider for that sale. And so we're looking at different models. So yes, you might see more devices in big box stores, pharmacies, grocery stores, Radio Shack, technology devices, things like that. But the OTC legislation is looking at decoupling the device from that provider.
Okay, there's a question from Tricia. What are consumers saying to you at HLAA regarding this legislation? Barbara, do you want to chime in on that as well?
Oh, sure, I'd be happy to. Well, many of our members tend to have more severe to profound hearing losses with very complicated fittings, and they have enjoyed the good care of their audiologist and hearing instrument specialist for many years. So this over-the-counter category really wouldn't apply to them, but they understand that with the innovation in technology and opening up competition, that it would be good for hopefully bringing all the costs of hearing aids down. And some of them have said to me, you know, I wish I would have done something sooner about my hearing loss, and I might have if something like this were available. And then, of course, we've heard from other consumers who think this is a good idea because they can't afford hearing aids. So, and then, of course, as I'm seeing from the questions, there's some really good questions about PSAPs and over-the-counter and what over-the-counter will look like. So well, I know we won't be able to get to all the questions, so I'm almost thinking we might need another webinar.
I think so. There are several more questions, and unfortunately we are not going to be able to get to all of them, but one that really sticks out is from Priscilla. She says, as a physician, what should I tell my patients about the OTC devices? Do you want to take that question, Alicia?
Sure, I'd be happy to start. First and foremost, thank you for being on the webinar, because there are so many physicians that I speak to on a regular basis that are not interested in hearing or balanced healthcare for their patients. So thank you, thank you, thank you for being one of those select few, and please lead your colleagues along the way as well. I think what you need to tell your patients is that at this point in time, start with the audiologic evaluation and then move forward from there. So this is OTC legislation is something that they can look into, but it's not something that's going to happen overnight. There are devices that are out there, but because they may not be the best regulated devices, it's not something that patients should just go out and start purchasing on their own. Right now, the model of care is still going through that audiologist, and I would hope, as in terms of evidence-based practice and best practices, that you would want your patients to have that baseline evaluation before any type of treatment is there. That being said, I would strongly encourage them to be active and be looking at this and be asking and be well prepared when they go see a provider, so that they can say, are there low-cost options? Are there treatments that are available for me that maybe aren't hearing aids but more assistive listening devices or communication strategies? And you should be engaging your congressional members that you've elected to do what you or your patients or their family members think are best. That's why we elect them. And so that's what I would say to you as a physician, and that's what I try to tell my physicians when I meet with them. So Stephanie, I don't know if you have anything to add from what you're seeing with other audiologists as well.
I think that's excellent advice. We are seeing that there are more audiologists who are utilizing some of the PSAPs and other products within their practices. So I think, again, if the patient seeks out an audiologist that offers some of those types of alternatives and get the evaluation, and then know that there would be some low-cost or alternative options for them.
We hear quite often from people that say their physicians told them it was just part of aging, you know, just turn up the TV, and really nothing can be done. So as long as you don't tell them that, that there is help available, and we appreciate you being on the webinar tonight. Thank you so much, Alicia and Stephanie. Unfortunately, we are now out of time, and I apologize that we cannot get to all the questions. That just makes me think that we need to get on the calendar for a second webinar, and maybe by the end of summer or fall, a second one would be timely, and we'll be able to give an update on what the legislation is doing at that point. So thank you all for attending this evening, and thank you, Alicia and Stephanie, so much. This was very informative. I appreciate it.
Thank you. It's been a pleasure.
Same for me. Thank you very much.
All right. Good night, everybody.